Hello, this is Dr. Girish Rao here from the channel Learn Maxillofacial Surgery. We're going to show you a video of how we manage a dentigerous cyst involving the right side of the body of the mandible, involving the second molar and a displaced third molar. A biopsy was earlier done, and we were suspicious whether it could be even an odontogenic keratocyst, but the histopathology confirmed our clinical diagnosis of a simple dentigerous cyst. It's a large cyst, so we are planning to do it under general anesthesia. An incision is made. You need to make your incision, clavicular incision, on the gingival sulcus, and a vertical relieving incision is done in the premolar area. We're planning to take out the second molar along with the third molar and the cyst. That's the flap which has been raised. Very good idea to do a single flap. That means that you're using a mucoperiosteal flap. Never raise a mucosal flap and then raise a periosteal flap, because the post-operative swelling is going to be even more. You can see the previously operated site. That's the biopsy which was done. So a window was created in the third molar area from which the biopsy was taken. The cyst lining was sent for histopathology. With a fine round burr, you need to basically remove a significant amount of bone to get into the cyst. And once you've done that, then basically you can change into a rosette surgical burr, which trims the bone, and we are trimming the buccal cortical bone over there. Guttering around the second molar is usually done so that very minimal amount of trauma is created when you're elevating and luxating the second molar. That's the second molar coming out. The resorption of the root has happened, so you can see the complete tooth is taken out. And once you do that, then again you get back your rosette surgical burr, and you can see the way in which we are taking out both the buccal and the cortical plate. There was a perforation of the buccal cortical plate, which the cyst had already perforated. So I'm trying to preserve the rim of the buccal bone above the perforation, so that the height of the ramus of the mandible and the body in that area, in the angle region, is preserved. The wisdom tooth, which is displaced, can be a challenge. So it's a good idea to section the wisdom tooth, and guttering around the wisdom tooth will minimize the amount of bone which is removed to get the wisdom tooth out. Using a simple coupe lens elevator, it's gently teased out the split tooth. Again, you need to be extremely careful that you don't use too much of pressure. Very rarely you can even fracture and cause a pathological fracture of the jaw. So minimalistic finger pressure, don't use your entire wrist. So it's just a simple luxation which you need to do, and both the roots can be removed. So once it's split, it is so much easier. The entire tooth can be taken out in two fragments. Having removed the tooth, now you can see the remnant part of the cyst. So you use a Ward's curette and start enucleating the entire cyst, and that's what we're doing over there. Many a time small fragments are stuck, especially around the root sockets and below that, and it's absolutely important that you're very, very meticulous in terms of taking out the entire cyst lining. Different curettes can be used, different angulations, different sharpness of curettes. This is very, very important. Many a times you can have even perforations below where you have the canal, the inferior alveolar canal. So in this case also there was a perforation of the canal, which is the reason why we need to be extremely careful with the curettes. You need to take out the cyst lining, but at the same time you should not damage the neurovascular bundle. So very gentle teasing. Most of the times the cyst tends to come out pretty easily. Be very meticulous and do a thorough curettage. And that's where you can see the perforation of the buccal cortical plate. So there is a small slither of bone at the crestal area which we have preserved, and any sharp edges on both the buccal as well as on the lingual cortical plates is trimmed with a large rosette surgical burr. Copious amount of irrigation is used whenever you're doing any bone trimming or bone cutting, otherwise the bone can undergo necrosis. So you want viable bone in which we are going to put the graft. So it's very, very important that the cutting or trimming of the bone is done with copious irrigation too. And that's the trimming which we are showing there, the buccal as well as the lingual cortical plates. Now you can also, if you see carefully at the floor, you can see the neurovascular bundle there. That's the perforation which the cyst had created. So you can see the neurovascular bundle completely intact. That's very, very important because the sensation is preserved. The patient will not have a permanent numbness of the lip and chin region if you are respecting the nerve. So it's very, very important that you do that. That's the PRF. I like to, whenever I do a cyst, I like to add to my graft material either platelet-rich fibrin as either you can use platelet-rich plasma or the plugs which you can do, and also I use carnized solution. And this carnized solution is composed of a combination of 60% ethanol, 30% chloroform, 10% glacial acetic acid, and 1 gram of ferric chloride. It's a fixative agent, and it's mainly used in odontogenic keratocyst, where there is a higher chance of recurrence. But I tend to use even in these kind of large cysts. One of the advantages of this is even if there is a small daughter cyst, it's basically fixed. So the way in which you use carnized solution is you use a peanut. This is a small gauze which you pick it up in an artery forceps, a curved artery forceps, and essentially coat the entire cyst lining, or cyst wall basically. And once that has been done, you need to take out any of the debris which is there. So again, curettage. And I like to use a simple pass with a drill. And whatever fixative has been done, the chemicals which fix the tissues, that is all cleanly curated out, either with a curette or with a burr. So now you can see the bleeding, and that indicates that the cavity is again completely thoroughly enucleated. These simple steps will help in basically prevention of a recurrence. Bone grafts, you have a whole choice of graft materials. You can use alloplastic materials, or you can use xenografts, or you can use even the gold standard autogenous grafts too. For small cysts, good idea not to basically use autogenous materials. You have plenty of synthetic materials which you can mix with PRF and PRP, and that's very good. This is a PRF which we are putting at the base of the cyst cavity, and where the perforation was there, just above the inferior alveolar nerve, so that it basically helps in healing. So that's like a base. And there was also, as I told you earlier, a perforation in the buccal cortical plate. So you need to construct the buccal cortical plate, and that's where we use no bone putty. This is a nice material. It's tricalcium phosphosilicate in a binder such as glycerol, which basically holds the crystals together, and it neatly basically lines the area where you had a perforation. So this can actually be used to build up a wall, and the material stays there. So that's one of the biggest advantage. And into the cavity, then you can basically put any powder material. And this is xenograft which we are using here, BIOS which we are putting in there. Again, this is mixed with PRP, and we are packing it very loosely. You need to pack it, and you can use a small compression device on which you can just tease the material into the cavity and completely fill the cyst cavity. So that's the basic light condensation which we're doing. And the entire cyst cavity has been packed with the graft material mixed with PRP. Now you have created a membrane with the platelet-rich fibrin, and that is placed above the graft material. You can see the way in which we are laying the platelet-rich fibrin membrane on top, and this helps in, there's so many growth factors in platelets. These are the platelet-derived growth factors, and that helps in early bone healing. The key after you put the graft is basically doing what is called as a watertight closure. Any simple suturing technique can be used. Here we're using a interdental technique to bring the flaps together. I like to use a combination of interdental, where the teeth are there, and in the partially edentulous area I like to put a horizontal mattress stitch. The advantage of putting a horizontal mattress stitch is the fact that you get bunching of the tissues and good approximation, good aversion of the tissues, and thereby the healing will be very, very good. In addition to watertight closure, it is mandatory to have a tension-free closure. These two principles of suturing really helps in prevention of a dehiscence. Now, if you get a dehiscence when you put a graft material in, saliva and food material can go into the cyst cavity and your graft will get infected. So it is absolutely important that you do not get dehiscence. So you need to be extremely meticulous in the way in which you get your suturing correct. That's a hand tie. Again, hand tie is very, very useful. It approximates the tissues together with very, very good, ideal pressure. And in the vertical limb, I'm putting a mattress stitch there. So it's basically a square stitch, and that basically brings the tissues together with good aversion and a watertight closure. What is the suture material I like to use? Normally intraorally I use either a 3-0 or 4-0 vicryl. That's my favorite suture material. And that's the kind of closure which you can get. It's a watertight closure, and that's the post-operative OPG, which shows the bony cyst which has been completely enucleated. The second molar and the right side third molar has been completely removed with the cyst, and you can see the graft over there. I hope you enjoyed this video. Thank you.